Há 35 anos, a GFE embarcava no Brasil, trazendo soluções inovadoras da Bélgica e da Alemanha, que revolucionou e tem revolucionado a medicina no país. Em busca de aprimoramento tecnológico e científico, em 2007, novas marcas foram criadas e a empresa passou a oferecer um mix de produtos, transformando a rotina dos profissionais de saúde e contribuindo para uma maior eficácia do diagnóstico gastroenterológico. Precursora e referência em soluções para endoscopia digestiva, a GFE está presente em todo o Brasil, com a missão de atender às necessidades da saúde tanto no mercado público quanto no privado. Oferecendo soluções inovadoras e humanizadas com segurança e qualidade. Essa é a GFE. Com determinação e compromisso ao próximo, continuará olhando e trabalhando para o futuro de melhorias na medicina.
Boa noite a todos. É um enorme prazer estarmos iniciando mais uma das atividades da Comissão Científica da Sociedade Brasileira de Endoscopia Digestiva, hoje em um evento especial, na verdade um evento muito especial, em que nós vamos abordar erros em dissecção endoscópica da submucosa, como evitá-los. E para tanto, nós vamos ter o prazer de receber duas pessoas ilustres conhecidas mundialmente que abordarão este tema para que posteriormente possamos dirimir as dúvidas de todos os nossos subedianos. Nós teremos a palestra do Dr. Hiromitsu Ban e, na sequência, como debatedor, o professor Takashi Toyonaga, ambos da Kobe University Hospital do Japão, e que para nós é um motivo de enorme satisfação. Como moderadores, nós teremos o Dr. Nelson Miyajima, daqui de São Paulo, e além do Dr. Nelson Miyajima, também teremos o Dr. João Paulo Pontual, que é de Recife, em Pernambuco. Good night, my friends. Thank you, Professor Toyonaga. Thank you, Professor Hiromitsu. And very important for us, your participation. And I like to comment about the many other people's comment your presentation for tonight, because this topic is a very important topic. Dr. Hiromitsu, please start your conference.
So I'm very pleased to be here today. Also, I'm a little disappointed that I can't talk to you directly. I suppose time are hard of everyone because of coronavirus. I hope you find this meeting as helpful as intend it to be. At first, allow me to introduce you to my hospital. I work at Sessão General Hospital, which is in Shiga Prefecture. Do you know Shiga? Shiga Prefecture has the biggest lake in Japan called Lake Biwa, also known as Biwako. The hospital I work at stands nearby Lake Biwa here. The hospital holds about 305 beds, and we perform ESD about 150 times a year. So I graduated from Shiga University of Medical Science in 2002, and I worked at Shiga University Hospital from 2010 to 2018. I began to performing ESD in 2010 and handled about 800 cases during my time in Shiga University Hospital. But I wanted to study more about ESD and further develop my skill, so I moved to Sessão General Hospital in 2018 and learned more about ESD from Dr. Toyonaga. Today, I would like to share what I have learned over the years with you. I will be talking about the key points in performing ESD, highlighting what I thought were crucial points in the past 3 years of my experience. First of all, I will talk about the important things to be aware of before performing ESD, which are setting of the equipment, planning strategy, and sedation. The settings of equipment are, of course, not only important in performing ESD, but also in performing other endoscopic examinations and treatments. This slide shows how we used to set up for the operation of upper GI ESD at our hospital. This setup had two big problems. The first problem was that it wasn't good for the posture because of the way in which the equipment were placed. Because of the movement of my hands and my eyes were not aligned, it forced for me to twist my body in other ways during operation. This was killing my neck, shoulders, and waist, and this made it difficult for me to control the scope delicately and stay concerned over the long period of time. Second problem was that it was a little difficult to communicate well with one of my assistant staff because they would be stood behind me. And this slide shows the current settings of performing upper GI ESD. It found that it is highly important for the movement, the scope, and the eyes of the operator are in sync during the operation. The monitor and the devices are placed directly in front of the operator. And assistant is also standing in front of us as well. The setup solves the issue that the previous setup had. And now, the operator can control the scope smoothly without having to worry about back pain, neck pain, and so on when performing the operation over a long period of time. This slide shows the previous setup for performing lower GI ESD. This had the same problem as the old upper GI ESD setup. I've now changed the layout to this, which is less stressful than ever. On the next topic, this slide shows the previous setup of the foot pedals. I used to control the all pedals with only my right foot, but I sometimes stepped on the pedals for the electrosurgical devices by accident when I meant to step on the pedals of the water jet. Making mistakes when stepping on pedals can lead to serious complications like perforation or bleeding. So this issue had to be solved immediately. I've now changed the layout like this. The pedals for the electrosurgical devices are placed under my left foot and others under my right foot. It was a little difficult to control the pedals under my left foot at the beginning, but I gradually got used to it, and I no longer step on the wrong pedals. Next, to plan our strategy, we must confirm where the lesion is, check the maneuverability of the scope, and check the best position for the patient. They are all in fact connected. We choose the most suitable scope and the position of the patient, developing on where the lesion is. Additionally, the sedation method is also very important. I usually treat my patient with intravenous anesthesia. If we under-sedate the patient, they will feel pain and their body movements will become more rough. If we over-sedate the patient, they will most likely breathe irregularly and may even start snoring. Of course, you wouldn't need to check for these things when you would apply general anesthesia. Although these conditions are seen as highly dangerous when performing ESD, even if you are one of the most skilled endoscopists out there. To avoid these issues, I use dexmedetomidine and peptidine for the base. When the sedation is not enough, I adjust the dose by adding the dose of peptidine or flunitrazepam. I believe that every endoscopist who do ESD must ensure to study about sedation in order to treat all patients safely. This is the actual dose. The first 6 microgram per kilogram per hour of dexmedetomidine is given through continuous intravenous infusion. 10 minutes later, 35 milligram of peptidine is given and 0.5 microgram per kilogram per hour of dexmedetomidine is given. So next, I will talk about key points while performing ESD. First step, marking. We need to make sharp, clear marks approaching the surface of the area vertically. If you take the horizontal approach, you will not be able to see marks clearly, and which will lead to the problems later on, such as make a mistake on where to mark the incision line on the mucosa. When you need to change the horizontal approach to the vertical approach, you must press on the mucosa with the endoscopic fluid, or press against the mucosa with the knife and change the direction of the approach. Second step, submucosal injection. The first injection is most important one. If you cause the intramucosal hemorrhage upon the first injection, I would make it difficult to continue the operation around the area of hemorrhage, which may force you to change your strategy. The image shows the markings and the incision line. If you inject near the marks and hemorrhage takes place, it may damage the tumor. The guideline of the injection area is 1 to 2 knife lengths outside where the marks are. The third step, submucosal dissection. Typical case of submucosal dissection includes fibrosis, big vessels, and poor maneuverability. Next, I will talk about the key points of these cases. This lesion was recurrence of EMR of colon cancer. It was difficult to complete the resection with EMR because of fibrosis, and so I decided to resect with ESD. At first, I injected some hyaluronic acid solution, but the center of the lesion did not be lifted high enough. I performed the dissection around fibrotic area little by little using a tip of knife. This is fibrotic area. So this technique is useful for performing ESD on the severe fibrotic areas. So next, this shows following LSD NG region, which are the large vessels, large blood vessels. I needed to dissect the submucosa and needed to expose vessels to begin with. I dug out the vessels with a knife, and after that, I boiled the vessels using a low voltage setting with coagulation mode. And I cut down the vessels after boiling them completely. So this method is good for avoiding heavy bleeding of the patient. And if you have a case of poor maneuverability, try to change the position of the patient, control the amount of air and water, and use the overture of the scope at the colon region. The first step after dissection. And this is a further technique of mucosa detect after performing ESD. This technique is especially useful for colonic lesions. After the closure is completed, we can avoid delayed coagulation and post-ESD coagulation syndrome in many cases. This is a mucosa defect after colonic ESD. An initial set of space hemocrypts are applied onto a submucosal layer in the center of the ulcer floor. In a longitudinal direction, shrink the defect. And more clips are intentionally applied onto a mucosal layer in the space left between first set of clips from the previous shrinking procedure. always ensure to take breaks during the operation. I recommend it taking a 10-minute break every 2 hours and changing the patient position during that break time. And this picture, these are knives after performing ESD. The top one is new, the middle one is after some ESD action, and the bottom one is after some hard use. This is quite an extreme example, but the knife does perform little by little with use. If the knife appears to be less functional, consider replacing it. Lastly, I will be talking about how to further improve your skills. 1. Take brain endoscopic images in useful screening tests. Keep brain images in mind will give you a good visibility even during ESD. 2. Watch the video of your operation as soon as possible after ESD. Then you will be able to see your procedure objectively during ESD. 3. Observe the ESD performed by expert doctors. There are many tips and points that can only be learned by watching them. 4. Show your surgery to young doctors with comment. Teaching will deepen your understanding. 5. Plan and hold an event of ESD at your hospital. The level and motivation of your endoscopic team will be higher. So I planned it and held a seminar at August 2019. There were live demonstrations and hands-on at the seminar. And this year, Pinky Live Endoscopy has held my hospital in March. While the infection control of COVID-19, I studied ESD with about 100 doctors. And I plan to host the seminar again this year. I hope you found this presentation helpful. I hope to meet you directly in the near future for the chance to study about ESD together. So this picture is my endoscopic team. Thank you, my colleagues and Dr. Toyonaga, and thank you everyone for your attention.
I'd like to introduce Dr. Nelson Miyajima and Dr. João Paulo Pontual to begin the discussion with Professor Toyonaga. Dr. Nelson Miyajima, please.
Good morning, Professor Toyonaga. Good morning, Professor Pan. Thank you very much for your participation. Congratulations for a great presentation. Boa noite, amigos sobedianos, professor Eduardo, meu amigo João Paulo. Parabéns, presidente Ricardo Dibi, pela organização do evento, e professor Eduardo, aí, muito obrigado pela grande oportunidade de estarmos aí aprendendo com os experts japoneses. First of all, I'd like to ask Professor Toyonaga to start your comments and the introduction. Thank you, Professor.
Good evening, everyone. Good morning for Japanese colleagues. I enjoyed a lot this fantastic session. How are you nowadays? Professor Ban presented so many tips and errors likely we are taking, especially for the younger colleagues. But there's several points. First of all, position of the patient and the setting of the equipment is very, very important, as Dr. Ban mentioned. And I'd like to briefly add some point, because we are standing in front of the monitor, because we want to control the endoscope efficiently. That's why we are placing the monitor in front of the us. Of course, we are standing in front of the patient, as Dr. Ban mentioned. Second point, very important. Many Western doctors always holding the scope with their right hand, always, without controlling the insertion depth of the knife. That's why always you're coming closer to the target and coming back. But if you always holding the scope, the image is always losing the tension. So by crossing to the target, we are dividing the target by the distal hood. At that moment, we need to control the device very precisely. So please mind, you need also both control endoscope insertion and the left rotation, and also at the last, you need to control the knife itself by your right hand. So please keep your left hand strict, surely, and stretch the shaft of the endoscope and rotate the image by your left hand to allow right hand free. Then you can control the knife. This is the greatest step to control the knife precisely. Okay, any other comment, point, Nelson?
Yes, it's important. Sometimes you ask to the assistant to hold the scope. In what situation you?
Especially in the rectum, very close to the anal canal. So because the insertion, the length of the endoscope is very short, that's why very floppy. At that moment, I frequently ask my assistant to hold the endoscope shaft to keep the good position. But some expert doesn't like this fashion, but I'm much more taking priority to control the knife depth, because 0.5 millimeter control is needed if you dissecting the very fibrotic target. That's why I want to free my right hand. So assistance is needed in such particular case, situation, as you mentioned.
Okay, thank you. Dr. João Paulo, please join the discussion, please.
Thank you, Dr. Nelson. Thank you, Dr. Ban, Dr. Toyonaga. It's a great pleasure to be here tonight with you. And I would like to make a few questions about some tips on severe fibrosis when we encounter it. And Toyonaga Sensei has a few publications and maybe could share some tips of the electrosurgical unit settings and how to move. And mainly in few situations, it's very difficult to find the right plane in the beginning, like inflammatory colonic disease. Is there any tips you could share to access the correct plane?
Great point. First of all, you need to find out the dissection plane, as you mentioned. To do this, we are starting from the relatively less fibrotic area, and we expose the fiber optic care first. Then we inject or flush the saline through the knife frequently to clear the lumen target. And also, we are very precisely observing the muscle surface. You can see muscle bundle clearly if you dissect very deep. Then submucosal fiber is coming right, something like vertical, and the muscle layer is existing horizontal. So please try to find out these borderline. So additional injection, this is not aiming to the lift up, just to confirm the border. Then, but muscle layer is not always flat. Muscle layer is almost always coming up. That's why you cut deeply, you make perforation. That's why just tap here, very short conduction with the more incisive mode, such as the end cut duration 2 or 1. Duration 3 is longer duration, you are cutting longer. That's why for fibrotic target, I prefer to use the end cut duration 2 or 1 to tap very, very short, precise. Then tapping, 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 I'm creating the line dissection. So for coagulation, you are always making burn or chart. So also you are making bleeding during the dissection. In case of bleeding, I immediately want to conduct the coagulation mode by pressing the blue pedal. So I'm switching the coagulation mode and the dissection mode or incising mode by conducting the yellow pedal, yellow coag. So to conduct more efficient dissection, you need the water and the electrolyte saline. That's why we are frequently flushing the saline through the knife to keep effective dissection or cut situation. So not only choosing the device and also the electrosurgical mode, you need to control the technique and also situation. So everything should be prepared. So very difficult to say in one word, but so please observe the live session.
If I may ask,
again.
All right, sorry to interrupt. If I may ask, the blue, the coagulation settings for when there is a bleeding. Many times you mentioned to use forced coagulation in low settings or soft. Which are your preferred settings?
So for prevention, pre-coagulation, low setting the forced coag is better than the soft coag because it has a higher voltage. But if you set the watt set very short, heating up time is coming longer. It means we are using initial cutting phase without spark. That's why more coagulative, more effective pre-coagulation can be done. Please refer our article for the detail. So for pre-coagulation, it is very important to prevent the bleeding. But if you create the active bleeding, you need immediately emit the spark to stop or to minimize the bleeding. Then if you find out the bleeding point, you can much more precisely apply the coagulation, low setting or spark as well. But if you fail, of course, you need to use the coagulation grasper. So the immediate spark is needed to stop the bleeding during the dissection by knife itself. Okay.
Nelson, I have a question.
One additional point. Sorry. It's okay.
Yeah.
Please. Professor Mora.
Professor Tanaka, in severe fibrosis, sometimes type flush knife is big. So sometimes it's you prefer to change to needle type or another type of knife like a hook knife or needle knife or some kind of scissor.
Yeah, good point. In the past, I also thought about to change the device to the sharper devices, but bow tip has a round shape, and the spark ability is always same. It doesn't interfere by the direction of the knife. If you come, instead of changing the device, I'm changing the mode to the more incisive mode, such as the end cut eye, because bow tip knife is coming like this. Then, if you come vertical, oblique fashion and horizontal fashion, always current density is the same, and radial spark is coming. That's why I don't need, and also I'm dissecting by the spark, very high incisive spark, such as end cut. That's why I never need to change that device to the sharper one. Most important thing is to find out the exact dissection plane. Then just coming closer by using the tip of the bow knife, then spark very precisely. Unfortunately, in Zoom transmission, the video has skipped the initial spark in the Dr. Ban's video. I'm conducting very short current, as you see, you know, spark, tap, tap, tap. So, and also I'm observing the spark. So please remind, we are not cutting by manual fashion. We are using the electrosurgery. So spark is fundamental source for the dissection and cut. So please control the spark instead of the knife shape.
Interesting. Dr. Toyonaga and Dr. Ban, I have a question. How to define the endoscopic submucosal dissection strategy based on the lesion topography and morphological characteristics? Example, when you have the lesion in the right side or the left side, what kind of scope do you use? The colonoscope, the gastroscope? What the technique do you use? The retroflexion vision? When you start for the incision, is the distal point or the proximal point? How to define your strategy during the ESG?
Yeah, good point. But also very difficult to explain in very short time. But we are using three different strategies. One is the conventional flap technique. Second one is pocket creation method. And the third one is traction device assisted DSD. We have three options. And also, when you have the bulky lesion, it has a very high possibility of having the fibrosis in the center of the lesion. Also, it's also exhibiting the muscle retracting sign. In such situation, definitely I recommend you to start with the pocket creation method to keep the good counter traction in the submucosa. For the larger one, there are so many options, flap technique, traction, and so combination. Regarding the location of the lesion, of course, right-hand side colon, you need a colonoscope, and maneuverability can be controlled by using the balloon-assisted endoscope, as you see, or Dr. Ban mentioned. And for gastroscope, I don't like to use from the beginning because the shaft is relatively soft. So in case retroflexion is highly needed, such as and also it is very easy in the rectum. So in the rectum, I'm start from the gastroscope, but so many point is there. So please first select three option: conventional method, traction, or pocket creation. And also, please choose your preferred endoscope. But before choosing the endoscope, please check the ability of the retroflexion. In the West, many endoscope is only coming like this. We are using like this one. So the retroflexion ability is very important. So please maintain your endoscope frequently if bending is less than the new one. Okay, so of course some additional expense is needed, but very, very important to maintain the bending ability. Okay.
Nelson,
And
João?
can I pass a question from the audience? From Dr. Leaks from Campinas. He is asking for Dr. Ban and Dr. Toyonaga when we could indicate the traction technique. Is there a good moment, and is there any specific site of lesion that is recommended in early settings?
Yeah. How about Dr. Ban? Do you have any comment? Yeah. Actually, this question is also very difficult to answer in one word. So so please try the traction if you don't have any other option. So you can apply anytime you want. So, but don't depends on the traction. So traction assisted ESD is basically based on the flap technique. Just to enlarge the flap techniques. Just enlarge that. So before using the traction, it is better to learn or experience the conventional flap technique. And also for the pocket creation method, opening the pocket and finish the dissection or finish the incision, you need the experience of the flap technique. So basically flap technique. So please add traction when you want to cope the FIFA station. Do you have any additional comment, Mr. Dr. Ban? Please turn on the mic. Maybe muted.
Dr. Ban, can you hear me?
Okay. I have.
If you don't have the other one, it's okay.
Professor Toyonaga, when a patient is referred from another institution for resection, usually it's a more difficult case, a challenging case. When should we repeat the exam again for evaluation and to strategy to procedure? Always or sometimes? What's your strategy?
Sorry, I missed the first word.
When the patient referred from another institution to you perform ESD. So usually it's difficult case. In one situation, you repeat the exam to define the procedure or to take your strategy.
So I'm afraid I'm missing your question, but your question is how do we make the strategy right?
Yes, when the patient is referred from another institution, you
Another referred from the another.
yes, yes.
Yeah.
Right.
So still, I have caught your question, but of course, already well examined. We don't repeat the examination beforehand before ESD. But for the gastric case, it is better. For usually we are the detailed examination we are performing before ESD, because the border of the tumor is very subtle in early gastric cancer, as you know. But colon, border of the lesion is very clear. If the referring doctor captured a very good image, we don't need to repeat it. Just start from the beginning. But of course, many high volume center recommend detailed examination before conducting the ESD. I'm afraid I have already asked your question or not.
Yes. Indeed. Professor Toranaga, a little word about the caps and when to choose which type, and do you use, you and Dr. Ban, the tapered cap, the funnel type cap, sometimes not in the pocket technique, or you only use for the pocket technique? And then second question is, where you used to position the little hole to the water can sink and not accumulate, in which quadrant you used to position it?
Yes. Dr. Ban, do you have a comment at the beginning? But it's okay. For conical shape cap, it works very well to get into submucosa and to provide a good countertraction in the narrow submucosa. But I don't use it always, because it is difficult for me for the mucosal incision. And also, wider view is my preference. That's why only when we are dissecting very, very fibrotic area, or very closer to the appendix orifice, or the very closer to the diverticum, such very, very difficult situation, I'm exchanging the cap to the straight, from the straight one to conical one. Okay.
And another question was about the hole of the Olympus cap. There is a little hole in the side. Do you, in which quadrant do you, the professor used to put the hole?
It will be recommended to set the other side of the working channel, because the during the suction there is some flow from the hole to the working channel. But do you think does it work efficiently? Just having a small hole, I guess it doesn't work because of the membrane phenomenon. That's why I'm using the 4 hole and 4 slit. If you fix the slit and hole, do you know the slit and hole? Nelson is well known. If you don't see, please ask him to show. But if you fix that 3 hole and slit cap, it creates the small duct between the inside the cap. It can penetrate from the inside the cap to the outside the endoscope. So by the capillary phenomenon, water is going out automatically. So you can keep very, very clear visual field during the dissection. So I prefer to use the slit and hole type. Not only hole, that I believe it doesn't work totally.
And a little word about scissor type knives. Do you think it's useful? I mean, sometimes, or no, it's not a very good accessory for ESD?
Yes, it works, especially when the manipulation of the endoscope is very, very unstable. Just you are grasping target and conduct current, that's all, like the biopsy. But it takes longer time, and also the assistant need higher skill to rotate a proper dissection. So to be honest, I don't like to use the scissors type all the time. Very, very few difficult situation I'm using the scissors type. And also it is relatively expensive and without Voyager function. That's why I don't use it so frequently. Ok.
Então, Eduardo, eu posso continuar passando as questões aqui da audiência? O senhor quer passar algumas questões?
And brief comment to keep the performance of the device, especially need flash knife. Dr. Ban showed the damaged devices during the hard use, but much more important to keep the good performance. During the incident dissection, bleeding, stop bleeding, tissue is adhered to the tip of the knife frequently, and it is disturbing the spark. So flash knife can out and in. Then during that out and in, if you flash, you can remove the adhered chart very, very quickly. So please polish your device as much as possible to keep the performance of the knife. Okay.
And another question of the audience from Adriana Costa from São Paulo. She asks when to close the mucosal defect with clips.
Already Dr. Ban showed in the colon it's better to close the defect when you might cause the damage to the muscle layer to prevent the delayed perforation or post-ESD coagulation syndrome. We don't have enough evidence, but we want to do as much as possible to prevent such adverse event. So in the stomach, we don't close so frequently. Just damaged area is enough. In the colon, it's better to close entirely as much as possible. Okay. So there are so many mistakes likely taking, and also there are so many tips. I totally understand why Dr. Mora planned this session, but very difficult. But just this is beginning. So please observe experienced doctor's performance, such as Nelson. So first of all, observation is very important. Second, you need to do by yourself. At the last, please try to explain during the teaching. So see one, do one, teach one. So every learner want to be trained by the expert hands-on fashion, but it is very, very difficult for in the real patients, especially in Japan. Of course, we have many younger colleagues. We are training them by hands-on fashion because their taking responsibility as the doctor in charge, so we can share the patient. But for the foreign doctor, it's very difficult to share such hands-on session. But just observe, many cases works very well. Then come back to your own country, then you can perform it. And if, but during the procedure, you may have caused so many other questions or so many other difficulties. Then come back again, then observe, then come back again, then please try to explain or teach your own technique to your own younger colleague. This is a the gold way, golden gate to be expert. This is here we have the good example, Dr. Ban as well, and Dr. Nelson, who is one of my best students in the world.
That's fantastic. Dr. Toyonaga, dear professor, you'd like to thank you for your great contribution today. You are happy with the excellent level of presentation from Ben and comment from you. We would like to hear a final message for our endoscopists, young endoscopists, to like to perform the ESD technique. Thank you for your comment, and please, your final word.
Dr. Ban, please go ahead. Please say one word.
Today I'm a little bit nervous. So, but they glad to invite me to join this meeting, and I enjoy the presentation. So, in the future, I met you directly and talking about some ESD techniques and so on. So, thank you very much.
I also enjoyed a lot this session, and the congratulations for a great success in this session. And I hope we can visit the St. Paulo Lives course or other opportunity. Maybe next time I will bring Dr. Ban as my assistant. So see you directly very near future. Thank you very much. Obrigado.
Thank you. Pontual, você quer falar as últimas palavras, por favor? Agradeço a sua moderação, bem como a do Nelson. Vocês dois podem finalizar a participação para que a gente encerre a sessão, por favor.
Dr. Nelson.
I'd like to thank you, Professor Ban, Professor Toyonaga, always so friendly. It's a great opportunity to learn again. So I am really thankful for this great opportunity. Thank you, Professor Eduardo. Thank you, Sobedi. I'd like to see you in the near future. Thank you.
João?
I only would like to thank our guests and Professor Eduardo and Professor Nelson. We all learned a lot tonight.
Bye-bye. See you. Bye-bye, Ban. Bye-bye, Toyonaga. See you.
Arigatou gozaimashita. Otsukaresama deshita, sensei.
See you soon.